Katoa. Ko Diana Safeti Takuingwa. He mihi nui kia koutou katoa. I'm the Head of Department of Public Health here at University of Otago, Wellington. And it's my great pleasure to be introducing Dr. Ashley Bloomfield. Ashley graduated from University of Auckland Medical School. We won't hold that against him. 1990. He trained as a public health physician, and he spent many years after that working at the Ministry of Health in a variety of roles. And he also spent some time at the World Health Organization, primarily focused on NCDs, mental health. And then he went off into the DHBs, and he ultimately became the CEO of Hutt Valley DHB and then the acting CEO of Capital and Coast DHB. And earlier this year, Ashley was appointed to the role of Director General of Health. I personally have known Ashley for more years than I care to remember, probably getting up to 25-ish, something like that. Ashley is a very clear thinker. He's a very principled person, and he cares very deeply about the health of New Zealanders. But more than that, he's a really good guy. So it gives me the greatest pleasure to hand over to Dr. Ashley Bloomfield.
Well, kia ora koutou katoa, tēnā koe dai. Thank you for that introduction. I'll have to be a good guy now. I was hoping that one of the 40 people online, one of them isn't my boss, but anyway, I won't say anything that will incriminate me. So really nice to be here. I've sat in those chairs over the years and admired in those seats and admired the people down here speaking and some wonderful presentations I've heard, and so it's a great pleasure to actually be here taking the floor, and I certainly consider it a great privilege to be in the role of DG. I'm 3 months in now, and it's everything I expected and more. I'll talk a bit more about that. Apologies to some of you who were at the College of Public Health Medicine meeting, and I spoke there yesterday morning, so this a little bit of a rerun here today, and I hope that, like a good movie, it's even better the second time. So we'll see how we get on. I have got a few different ideas I want to share. And is that George Salmon I can see up the back there? George, lovely to see you here, and thoroughly enjoyed what you had to say on Wednesday evening at the college dinner, and your description of what the role of a ministry and a DG's role is in advising the minister and the government. I don't think you could get a better description in a textbook. It was absolutely spot on, and I want to get it from you so I can use it. So if I could follow up with you and get that, it was just a lovely description of actually the fundamental importance of the public service providing free and frank advice to governments as system stewards, and I'll come back to that theme of stewardship shortly. So Di came around to the ministry. She was there a few weeks ago, and she came up to my office, and we had for a cup of tea, and we sat down and looked at each other across the table and said, well, how did this happen? She's a professor. I'm the Director General of Health, and about 21 years ago we were madly studying for our exams, trying to keep up with now Professor Tony Blakely, who was sort of always seemed to be more than one step ahead of me. I don't know about you, Di. But here we find ourselves, you know, the mantle gets handed over and the baton gets changed, and it's wonderful to have watched Di and Tony and many of the colleagues that I trained with progress through their careers and contribute so much to public health, both in New Zealand and also globally. It's just wonderful to see lots of people I know from my career over the last 20, 25 years all arriving here, so that's great. So yeah, sorry I haven't got slides. I realise that's very non-academic of me, but I have taken to not using slides, and hopefully I can hold you as an audience without them. One of the wonderful presentations we had on yesterday morning at the session at the college meeting was from Liz Craig, now an MP and a public health doc, and very, very proud of her achievements in getting to the position she's in. And she gave a wonderful presentation on her role as an advocate around child health, and just the deliberate and planned and proactive way you can go about actually setting an agenda. It was a fantastic description of how, and thinking about our interest and our kaupapa around public health, how to harness the public in your cause, and it was just a great description. So I want to acknowledge Liz and her achievements as well. George's comments the other night reminded me of, fitted very well with the approach we're trying to bring at the ministry around leadership. So when I was applying for the job, I'll just touch briefly on that. That was a pretty rigorous process, which included an hour-long interview with Kim Hill, sort of sitting about this close to each other, with 2 psychologists in the room as well. And then the psychologists proceeded to interview me for another 2 hours. That was one step in the process. I managed to get through that bit of it, so that was quite, I survived that. And I got to an interview stage, and for the interview, they asked me to do a presentation on there's a need, judging by the report that had been done on the ministry last year, there's a need for the ministry to strengthen its leadership and stewardship functions. And what is that? You tell us about what that means and how you would go about delivering that and what success would look like in 90 days and a year. And I've realised my 90 days are up, so I better go back and see what I said. I'm pretty sure I've ticked off everything. And I did share that presentation with my senior leaders in the organisation. When I arrived, I said, here's my pitch, here's how I pitched to get this role, so you know what I'm about, and I need you guys to help us deliver this. But George, when he talked the other night and was talking about the role of the public service in providing free and frank advice to governments, it reminded me of these, these fundamental features of a strong public service. And these, I think, are, believe it or not, are most encapsulated in the New Zealand public service more than any other in the world. And they're around transparency and openness, the provision of free and frank advice, as I've said, merit-based appointments, and also this notion of stewardship, having a future view, and I'll come back to that. And to me, that's encapsulated in the second word of this public service, which is around service and servant leadership. So we are here to serve the public. And 20 years ago or so, just over 20 years ago, when I was doing my registrar training, and just before I met or got to know Di and Tony a lot better, I decided to round out my public health training. I'd done 3.5 years in Auckland in various roles. I needed to come to Wellington for 6 months to get a bit of policy experience in the Ministry of Health. And so I stopped in here on the way back from the scientific meeting, the college scientific meeting in Dunedin. I met with Wendy Edgar and Andrew Holmes, some of you may remember them, sat down for an hour or so and talked with them, and they took a punt on me and created a role. I then had to ring them back a little while later and say, actually, my wife's pregnant and we've got a baby arriving in the middle of the year, so can we just defer that 6 months so that she can sort of be around her family, at least for the first wee while. So we arrived down here a few months later than originally intended, and I dare say for 6 months, and I stayed. And one of the reasons I stayed is, well, we loved Wellington. Well, I loved Wellington, and a few years later, my wife loved it. My mother-in-law still has serious doubts. But just being a public servant seemed to click, and there's that enormous alignment between public health and public service that for me has just been a wonderful sort of interweaving, and that's why I stayed quite a long time in the ministry. And then I had the enormous pleasure and fortune to go and work at the WHO. And I came back from there and I said to my colleagues in the Ministry of Health, I said, well, I said the Ministry of Health is a wonderfully flexible, adaptable, highly well-oiled bureaucracy, because I've just worked in one that isn't. So, the WHO is one of those things, like the whole UN system, I think that it's exceedingly frustrating, but also we are much better off with it than without it. And especially for small countries like our own New Zealand, we have a deep investment in seeing that the UN and those global intergovernmental institutions succeed, and that's why I think New Zealand has always been a major contributor and player to that. So let me move on then to the government's agenda around health, and I hope some, if not all of you, have had a chance to listen to the current Minister of Health, Dr. David Clark. He's a doctor of, he's a real doctor, a PhD doc. He's got a PhD in theology, and most of you probably know he's not just a minister of the Crown, he's a minister of the cloth, of the Presbyterian variety. He's a super fellow, and here's another interesting fact for you. I started medical school at a very, very young age because I was in the same class as his mother, actually. Faye, who was an older student, wonderful person, she had a family and then went back to school and got university entrance. then started a science degree, then got into medical school, and hence we started in the same class, even though she's a little bit older than me. And she was a GP. She specifically did it because she had a commitment, partly driven by her faith, to be a GP in Otago, where she spent her career, and she still does work, particularly in family violence. So that's the environment that the minister grew up in. When I first met him, I said, because he'd said in an article that he used to, sometimes during the holidays, when there were lectures on, he'd be dragged along by his mother to lectures and have to sit at the back of the med school lectures. And I did say that I didn't recognise him from the lectures. He was about 8 at the time. I was a little bit older than that. But one of the things you will hear him say if you listen to him is he says, the reason I got into politics was equity. I am here because I want to advance equity. I want to advance fairness. I want better outcomes for groups who are disadvantaged in this country. So that's his. And we've been having a lot of discussions about how we pitch his priorities, but he's really clear. That's my overarching theme. That's my overarching kaupapa, my raison d'etre here as Minister of Health. Fantastic, good, first tick for us in the public health area. And then he says, and here are my priorities: mental health, primary health care, child health and wellbeing, and strong, publicly funded, publicly delivered health care services. Well, if you're from public health, that's pretty much a dream list, really, isn't it? With equity as the banner and then those things, because it opens up huge opportunities. There's nothing about waiting lists. There's nothing about hospitals per se, but he has a very strong system view, and that's why he's commissioned the Health and Disability System Review. I'll come back to that. And he talks about that as a once-in-a-lifetime opportunity, once-in-a-generation opportunity, and it's one of the reasons that he was happy to take over the opposition's health spokesperson role from Annette King, because he wanted to, if they became part of the government, to initiate and see through that review. So I think, again, I think that's a bit of a dream list of priorities, and certainly from where I sit, coming into the role as Director General as a public health doc, and a deep commitment to the public health system in New Zealand, healthcare system and public health in New Zealand. It's a fantastic alignment of values, and so I'm really excited by that opportunity. So just then turning to the role of the Ministry of Health, most of you will know the Ministry has had a bit of a bad rap of late, and last year there was a report. There's a process that government departments and agencies have to go through called a PIF process. It's Performance Improvement Framework. It's never much fun, but for the Ministry last year it was even less fun than it might be even on a good day. And I've talked about some of the key findings of that were around the Ministry needing to really up its game around leadership and stewardship. So here's me sharing my ideas, and again, apologies to those who heard this a couple of days ago, but you'll now be able to recite it, about what sort of leadership are we talking about. So my definition of leadership, and I have some of the faculty at the Oxford Strategic Leadership Program to thank for this, because I think it's a really nice definition. Leadership is about ensuring direction, and very clearly not giving direction. It's about ensuring it. There are different things. It's about generating energy and getting focus and commitment to deliver. So I just really like that as a kind of min-specs definition of leadership. And then you can think all the time about, okay, are we ensuring we've got direction here? Is it clear what the vision is? For me, it's for the organisation as well as ensuring it's there for the wider sector. Are we generating the sort of energy that's needed to deliver what's needed for New Zealanders? And then we get that focus and commitment across the sector. So I've been clear also, and Stephen McCune started the Ministry on this journey when he came back from the consulting world. He told me he saw the phone ring. It was Peter Hughes. He had his number in his phone, and he answered and he said, "Peter, I don't think I want to take this phone call." And Peter said, "Yes, you do. Yes, you do." So good on Stephen. He stepped away from his consulting role at EY and came back to the Ministry for 3 months during that interregnum, and just helped really stabilise the organisation and shift it into a new way of thinking. And I've been really lucky to follow on from him and sort of pick up some of the work he had started. So just in that, I can say, as I expected, and as is my experience from previously, it's an organisation full of people who are extremely strongly values-driven, extremely committed to their work, and we're just waiting to be unleashed. The latent energy, there's no problem with generating energy here. It's there. So that's been great to inherit that. And so the leadership we're trying to demonstrate, the ethos, the approach is one around convene and collaborate. It's not command and control. And it's not command and control for very good reasons, because as I knew, but has been made very clear to me over the last few months, despite what people think, we have very few levers directly to command and control DHBs in particular on what they do, let alone the other providers that aren't effectively Crown entities. So we need to use, we don't have like other government departments or areas of government have, like the police, even MSD to some extent. There's a very strong line of sight from the chief executive of MSD or Oranga Tamariki down to the front line, and there's a very much, and of course police as well, much more command and control, corrections, these sorts of organisations. But of course, our workforce are in the health sector, they're all trained professionals, none more highly trained than the medical workforce. And I can remember in year 3 at medical school doing one of my projects on professionalism and what's the definition of professionalism. In a sense, medicine is the archetypal profession if you define it by the degree of autonomy people have over their work. So of course command and control doesn't work. I can't tell you, probably pretty much every day I get asked by someone to write a letter to the DHBs to instruct them to do something or not do something. It's my expectation you will do this, and I have to gently sort of pull them back and say, actually, we've got an issue here. Writing the letter won't change things. So we're very much moving, and again, Stephen set the scene for this, moving into this leadership about convene and collaborate, and then, of course, you create this mutual trust and obligation and accountability, and therefore you can have expectations on each other. And of course, that's also what lies behind alliancing as an approach to the work we've been doing with primary care over the last few years, is that high trust, high accountability, shared accountability, holding each other to account. Believe me, people hold the ministry to account. I'm quite happy to share that accountability. So leadership and then stewardship. So stewardship's this really important notion around the public service. And I talked up the New Zealand public service a little bit earlier on, by no means perfect, I can tell you, but routinely, year on year, Transparency International judges the New Zealand public service as either the least corrupt or second to that in the world, and the latest rankings confirm that. And it's not till you've actually been and worked abroad and seen the way that other public services operate that you realise. For me, it was something I took for granted as part of that public service till I went to WHO and had some interactions with public servants and governments of other countries, and realised that actually we're in quite a small minority in the world in terms of that lack of corruption in the public service. And fundamentally what that means is that when the government votes money for specific purposes, it has a really, really high level of confidence that the money is going to go for the purpose it was voted for. And that's not the case in probably most countries around the world. So we're very fortunate here. So this idea of stewardship, of course, which is of fundamental importance to the public service, is that we're not just trying to get the best for New Zealanders, for the public out of our current set of services, but we've got an eye to the future. We're thinking, how do we make sure that we are still able to do that in future? And at the moment, we've got a health system where a lot of challenges and pressures are all coming to bear at the same point in time. So it's doubly important for us to really carry that stewardship function very strongly. And a good example is in terms of buildings and infrastructure across the health system. So many of the buildings, many of the hospitals were all built in the 60s, 70s, perhaps early 80s. And those buildings are effectively coming to end of life at the same time. That's one thing. At the same time, we're all getting seismic assessments done on all our DHB facilities and finding that many of them are really don't meet a standard that an office building you would expect, and certainly not a place where you might be providing care for people. And third, because of the constraints around finances in the public health care system and in the DHBs over the last particularly 4 or 5 years, but really since the GFC, one of the ways that DHBs have made ends meet is to reduce their depreciation budget every year, and therefore their expenditure on maintenance. So there's a lot of deferred maintenance that's coming home to roost now, and you can just see this right across the country. So there's an eye-watering investment required in infrastructure and hospitals over the next 10 to 15 years, which provides a really good opportunity, of course, from a public health perspective to think, how could we do this differently? Yes, the investment will be required in hospitals, but also we need to open up the ability for government to invest in non-hospital infrastructure in the community. And that's not something that is necessarily enabled at the moment, and we're just doing some policy work, because I'm very keen, and I've had the conversation with the Minister, that as or before we embark on starting to do some of these big hospital builds, future-proofing facilities for the next 40 years is fundamentally got to start with, well, what's the model of care going to be, and therefore what are the facilities we need, and they may not all be on a hospital campus. So there's an opportunity and a challenge. So the stewardship role of the ministry is very, very important. And I think now I probably better get to the topic I said I would talk about, which was, let me just check this, something about sort of successes, challenges and opportunities for public health. So in terms of successes, I was giving this some thought, and I don't know if any of you saw the Health and Independence Report 2017. This is one of those things you have the good fortune of walking into an organisation and having your name attached to the bottom of a foreword. And I surprised quite a few people in the ministry, I think, by actually reading things that came to me before they then went on. And they learnt very quickly that I quite like detail, especially early on, so I can get my head around the issues. So there was a lot of material that got sent back with my questions or comments or requests for further information. And the forward of this document is about the only thing in 3 months that I haven't sent back, because it was very, very well written as it was. And I was quite happy to put my signature to it. And I was very happy to have my name associated with a report I had nothing to do with developing. A very, very good team in the ministry did. But I really commend that report to you, and it even got a sort of big ups in the Lancet got pointed out. And I had a colleague, Gordon Galia, who some of you may know from WHO. He's now the country rep in China, which is a very significant role in WHO. And he sent me a message saying what a wonderful piece of work he thought it was. So many of the successes of public health are in this document. I really commend it to you. And just to read through a few, most people rate their health as good in New Zealand. We are living longer. Not surprisingly, health loss from long-term conditions has increased over time. There's this wonderful notion of ageing as humankind's greatest achievement. It's a nice way to think of it. But with that achievement, of course, come some things we know are predictable. The rate of premature deaths has fallen. Rates of disability vary by age and ethnicity. And there's quite a bit in here around inequalities and inequities, which has really got to be a focus for us. But some of the successes in there, and some of them that I certainly would point to over the last few years, have been around immunisation rates. I think something we've forgotten pretty quickly, but our management of the pandemic in 2011 was actually outstanding in terms of reducing its impact in this country, at least. I think overall health improvement, notwithstanding, we've still got those significant inequities, but what an opportunity with this government and this minister to really have a look at that. So the challenges then, as I say, are around inequities and outcomes. And, you know, people may know my long-standing interest in tobacco control, and that's still a major driver. Smoking is still a major driver of those inequities, and a very preventable one. We've got to also tackle alcohol, and that's going to be a really interesting one for this government, because it will almost certainly be something that will be highlighted by the mental health inquiry that Ron Patterson's doing. He can't get away from that. One of the other areas of work I'm heavily involved in as a member of what's called the Social Wellbeing Board, which sounds flash, but it's basically the chief executives of social agencies and chaired by Peter Hughes, head of the state sector. That Social Wellbeing Board has an overview. One of our big areas is family violence, sexual violence. And if you're not going to tackle alcohol and harmful use of alcohol, you may as well shut up shop and go home. And we're all really clear about that. That's going to be a tricky one for this government to navigate through the current coalition arrangements. And they know that, and we know that. And our job is to help them do that and try and improve outcomes in that area. Water quality is one in terms of a current challenge that we're pretty focused on. It's one of our big priorities. And again, not straightforward, and will require quite significant investment in future years to look at. Obesity, I've described previously as the public health challenge of our generation. I'm always optimistic about obesity, because the amazing thing about it is how rapidly it developed. It's just phenomenal. You can see this epidemic develop over the period of 20 or 30 years, which means that if we do the right things, we can reverse it just as quickly. The challenge is that doing the right things to do require an enormous dollop of political courage. And so we've got to create, as the Minister says, the social licence for politicians to have that courage. That's a job for all of us. I think mental health, and this is one of the Minister's priorities, and I've talked about the mental health inquiry that's underway, is a big public health challenge for us, and suicide, of course, is writ large as part of that. I think there's a really good opportunity for those of us working in public health to get right in the middle of that and be influencing and supporting the outcomes of that inquiry and just the response to it. I'm very confident, and it's certainly part of our thinking, that the response will be very upstream focused. The investment needs to be in prevention and early intervention and providing options in primary and community settings for people with mental distress, mild to moderate conditions, who actually only need they need a very timely and often a very short and neat intervention to get them back on track. But it's the absence of that that then leads them into the specialised end of thing. And so a system that was invested in 20 years ago for 3% of the population is just groaning under the weight of the number of people who are going into that more complex end. So mental health's one, and I've talked about infrastructure and health system infrastructure, including IT, is a big challenge for us. So what are the opportunities? Well, building a little bit on what I talked about yesterday morning. So I just have to, my writing's a bit small here even for me. So what are I'll talk about them as leadership opportunities. Well, the first one is just really encourage you to get behind the agenda of this Minister. As I say, I think it's like a dream agenda for those of us in public health. And if you saw the Prime Minister on Sunday, flanked by her two leaders of the two coalition parties, presented the government's priorities, and there are 12 areas there. Health's one of the specific areas, but from a public health perspective, there are many others that we would have a strong interest in around, of course, environment, transport, and others, housing in particular. So I'd really recommend you familiarise yourself with that set of priorities. It's an eye-wateringly ambitious agenda, which is good. We should have high ambition. I've certainly got ambition, really high ambition for our organisation and for the publicly funded health system in New Zealand and for public health. Ambition's not a bad thing. And yes, there's a lot of expectation. I feel it on me, but I also feel the support that's there for us to deliver on that. So thanks to you all in advance for your support. So get in behind the Minister on the agenda and the government and their priorities. I think have realistic expectations, high ambition, but really realistic expectations. My sense is that some of what's the challenge for this government at the moment is that everyone expects all the issues to be sorted within the first 6 to 12 months. And the risk there is, and combined with their level of aspiration and ambition, that it overwhelms them somewhat. So we have to make sure we're helping them from where I sit to sequence how they can respond to what is a pretty long list of priorities. Think about that stewardship role. I think if I think of professionals across the health system and beyond, those of us trained in public health do bring a system view to our work. So think about that and think about, okay, how do we make sure that our work, our thinking, our advocacy is supporting future well-being and a future healthcare system that is going to be able to support. And I'm talking about healthcare system in the broadest sense, from what people can do for themselves in their own homes through the broader population health things, through to good palliative care right through. I'd really encourage you to engage with the Health and Disability System Review that Heather Simpson's leading. As I say, the Minister talks about this as a once-in-a-generation opportunity. I agree. I think there's a very big opportunity for public health to be influencing that, not just thinking about public health per se, but bringing our system perspective to what we might need to improve health and wellbeing for New Zealanders in the future, including the huge investment we make, currently $18 billion a year in our healthcare system. I think there's a real need for us to innovate a bit in public health. Actually, I'd say a lot. I think we need to innovate in our theology and in our practice. you know, some of the core theological documents of public health, like the Ottawa Charter and others, are decades old now. I'd love us to be thinking, okay, well, what's the new theology? Let's get our brains together and be thinking about, okay, we're in a whole different world now. We really are. What's the theology? Let's drive some innovative thinking around the sort of the core theology. I call it theology. I'm sort of quoting Don Matheson used to talk about the different churches of health promotion, public health, and primary healthcare, and we'd sort of have these theological debates about who was the most important, but actually our fundamental values are the same. But driven by the same values, let's think about whether we need to tweak the theology, and certainly whether we need to tweak the practice of public health and innovate in that area. I'm looking forward to some discussion around that. And finally, and this builds on the theme that we had at the college meeting yesterday, is about partnership. You can't do anything without others. Success is around bringing talent together, a lot of hard work, and I talked about ambition, having really high ambition. And ambition is a good thing. It's about seeing possibilities and not being prepared to take anything less than the possibilities that you're anticipating. So I encourage us to all do that. And, you know, I think that's about all I want to say. I don't know if I've spoken to what I said I would, but that's what I wanted to say, and I'm welcome any questions or conversation about any of that or other public health issues. Cheers.
We've got time now for some questions for Ashley.
Got some microphones here, and there may be questions coming through remotely as well. Perhaps here, while we're waiting for the microphone to go up, remote question.
From Clive Aspen, he says, Dr. Bloomfield, what is your vision for Maori health?
Yeah, so look, this is really important. I'll talk briefly around this. Just doing a bit of a restructure at the ministry at the moment. It's not something you want to do when you come as a chief executive. People expect you to do it, and I've got very good reasons to do it in the ministry. And one of the areas I'm wanting to strengthen is our capability and capacity around Māori health. So what I do want to do is just comment briefly on the importance of distinguishing between our accountabilities and responsibilities for Māori health, distinct from our responsibility for equitable outcomes. So they're obviously related. The Māori health one is a treaty obligation, and I absolutely get that, and I'm talking about that, and we are going to organise ourselves so we can improve Māori health outcomes inside the ministry and work with the sector to do that. I'm encouraged by some of the developments that are happening both within the health sector and more widely in society around just a high level of interest, a high level of awareness, and a high level of preparedness to engage with the sorts of tricky issues we need to engage with and be open about and be prepared to have the discussion around racism, institutional racism, and so on, because that will help us on the journey. So that's a comment. The second thing is we've got the some of the inquiries the inquiries by the Waitangi Tribunal around a range of issues. The first that's coming up, the Y2575 hearings, which are later in October, are around primary healthcare, and I'm going to be kind of representing the Crown's position at that and talking about what's happened for Māori and Māori health since the primary healthcare strategy came into being about 17 years ago. And again, our approach to that is not to be defensive. It's actually to let's open up the conversation. Let's talk about what's happened, where it went well, where it didn't go so well, and then see what comes out of that inquiry. But by the same token, I'm not going to wait till the inquiry comes through. We need to get on and do things now and then be further informed by what comes out of the inquiry. So I think that's another really good opportunity for us to think about how we need to do things differently. Thanks, Clive. Philippa.
Kia ora, Ashley. Thank you very much for sharing your vision with us, and delighted that you got the job. I was wanting to pick up one of the points that you made from the State Sector Review, which I've just used with my students, because it's said, how would you like to have all these red boxes on your assignments? It's quite a challenge that's laid down there. And one of the main criticisms about working across sectors, and you mentioned, in your final comments about transport and housing, and we found it quite difficult to engage on both those issues, particularly the housing with the ministry, and I wondered what your ideas are for the working in these sort of fundamental determinants areas. I get the health services and the disability and so forth, but what about the structural aspects?
Yep, and mea culpa, Philippa, for not emphasising that more in my talk. So two things here. One is just in terms of that, how we organise ourselves in the ministry. So one of the new directorates I'll be establishing is around population, primary and community health, with a much stronger focus and clarity around public health and that mandate around intersectoral work. So that will hopefully it will be easier to engage with the ministry. It will be clearer where to go. So the people in the organisation have got permission for a start. The second is if you go beyond our PIF review to the recently released proposals around the reform of the State Sector Act, they are specific. One of the fundamental drivers of that is a desire by the government, and certainly driven also and supported by Peter Hughes, to make it easier for different parts of government to work across, because at the moment the state sector, had some excellent. It created some excellent results and outcomes for the public sector and for public services, but the huge challenge there is the nature of the accountability of chief executives and of vote ministers means it's incredibly tricky to do things across votes and across ministries and departments because of the way the money flows, and that's also the Public Finance Act, which is going to also there's a consultation on amending aspects of that as well. So there are some sort of fundamental elements of the whole legislative context within which we work, which are going to change, that will make it not just easier, but will also create an obligation on chief executives of government departments to work across. So second, and one third quick thing is the government's 2019 budget, flagging as a wellbeing budget, and we've had a really clear message from the Minister of Finance that the only bids that will get through are ones that are cross-agency ones. So yes, there will be some, there will be necessary investment in cost pressure areas, and some of those will be in health. But the new things around the priority areas like child wellbeing and mental health need to be cross-agency bids. So that will, I think, is already driving different behaviour. Thanks, Philip. Michael. Microphone's coming. Oh, we've got it up here. Well, the microphone's coming in there. Kia ora. Well, it's now's a really good time. So we've got an Associate Minister of Health, Julianne Genter. She's currently having biked to hospital and had her baby, is on maternity leave. And James Shaw, Green Party leader, has actually got her portfolios, and this is one of the areas she's very keen to see progress on. And in fact, I had a brief one-on-one meeting with him earlier this week, and he said, I haven't seen any update on climate change and health in the last 3 weeks since I started. Can I have one? And I'm pleased to say we've got work underway. And Richard Jane, who's Public Health Doc, I'm not sure if Richard's here today, but working in the ministry, he's got the lead on this with one or two others inside the ministry. So there is a program of work underway. But from a political perspective, there's this really strong interest in there, and people in key portfolios who I think will be keen to drive this. And speaking with Minister Genter, that's in a couple of areas that are priorities for her, and they are in the letters of expectation to district health boards around active transport. Yes, I cycled here today. You can see my helmet, but also sustainable building and buildings and infrastructure, particularly with new big building investments coming into the health sector. So there are a couple of ways that are already we're doing some work on. Michael.
Yeah, kia ora, Ashley. And I was also fortunate to hear you speak yesterday, and I can say it's even better the second time.
Michael, I'll buy you lunch after this. Yeah.
And it has to be a wonderful alignment of the planets, the combination of reforming government and a minister with wonderful values, and yourself being there now. I wanted to ask you about another aspect, which is really another form of, I think, failing infrastructure, and that's really our health protection infrastructure in New Zealand. And often it doesn't really make it maybe onto the top list of things to fix. And I know you mentioned the 2009 pandemic. The reason we got off lightly is simply that it was a mild epidemic. It wasn't really something that tested our systems. Obviously, there will be severe pandemics in the future. If we look at Havelock North, clearly that's aging infrastructure in terms of the physical aspects, but also in terms of the organisational arrangements and the legislative base. You know, we have a 1956 Health Act, and this whole area has been, I think, neglected for a very long time. I'm just wondering if how that fits into the agenda, because we have both, I think, decaying structure, but also huge fragmentation in that area. Where is that on the agenda?
Thanks, Michael, and very kind of you to very gently correct me around the dates of the last pandemic, 2009, not 2011. So yeah, this is an issue, and while I was still a CE at Hutt, Dale Bramley, who's one of the other public health doc CEs, and I had a chat about this because we both were worried about public health capability and capacity sort of across the sector. So we started a bit of work with Caroline McCune inside the ministry, and that work's already underway. I think the water, you know, the water quality issue in Havelock North was a symptom of this, and you know, in a way, it's all very well to blame the ministry for not doing its job very well, but people inside the organisation can only do as much as the resources that are provided them to do the work that they need to do. So my sense is that, well, this is a priority for me. That's all I can say. What I really am interested in is us also rethinking our public health unit structure and so on. I don't want to get caught up in the sort of endless discussion around national, regional, local. We've been round and round that merry-go-round several times. Just, you know, what is it that we need in terms of infrastructure and capability out in public health units or whatever might come next? How does that interact with the wider health system? And I'll come back to that. And also then, what sort of arrangements do you need between those regional or local units and the centre? My comment about interacting with the local health system, my experience as a CE was really interesting, that because of the current the arrangements between public health units and the ministry, there's still a bit of a distance between the activities of public health units in terms of health promotion in particular, and what DHBs are trying to drive as the accountable local Crown entity for improving the health of their population. And I think we can just do better. And I'd love to see that happening. You know, I have a view, and maybe it's one that people can test, that there's nothing public health units should be doing for their local populations that their DHBs aren't kind of already wanting to do, you know. So they're there to help serve that agenda of their local DHBs, as well as those legislative roles that do tie back to the ministry around health protection. So both are on my radar, and you know, I'm really pleased to have someone of the calibre of Caroline McCune in there in that Director of Public Health role. I think we need to increase our capability and capacity in the ministry, and then as part of that, have a look at the wider infrastructure across the sector. Ruth, we'll take one from the remote folk. Back to Ruth.
What will the place of the 2016 health strategy be in the future?
Good question. So the comment I would make is that I meet with the Minister twice a week, at least, probably talk on the phone every day. The only time he's mentioned the health strategy to me is to say that he's disappointed it doesn't have the word equity in it anywhere. So that doesn't mean it's not there, but his agenda is driven by those priorities that I outlined. And yes, you know, what's in the health strategy is probably not, doesn't contest necessarily with that agenda, but I think that his agenda is a slightly different one from what might be articulated in that strategy. So as a matter of emphasis, yes, there it is, but our priority is on delivering on the Minister's priorities and the government agenda. Is that clear? Yeah, it's probably a bit of bureau speaking there. Save me, Ruth. Yeah.
A quick one from Ruth Richards, who no longer works in public health, but has great interest. Last year I went to a conference in Europe. The 3 words that came out were public health needs to be bold, courageous, and leaderful, or else it becomes irrelevant. You have described that beautifully. What I want to ask you is, does this leaderfulness plus the boldness and courage come just from the top down, or does it come from the bottom up, from the grassroots, the people who actually know quite a lot about public health, but they're never sort of quite asked about it?
Well, it's a sort of rhetorical question, I think, Ruth. Servant leadership is about enabling the people right across the system to lead as well, isn't it? And I mean, I don't do most of the convening and collaborating. It's the people who work for me. And so, I'll get together with the DHB chief executives and set the tone of here's how we're going to interact with DHBs. But what then I expect and I see in my own staff is them having also shifted the way they're interacting with DHBs, with other stakeholders and more widely in the sector in all of their everyday interactions. And that's the leadership I'm expecting and people to show, and they do actually, they want to be enabled to do that, which is great, or my job's to sort of unleash it.
Thank you, Ashley. When I was thinking about whether I should become a public health physician a long, long time ago, my father suggested that I go and talk to a friend of his. This friend had recently been the Director General of Health, and it was kind of terrifying going to talk to someone, at that level. You don't get much higher than that. That was George Salmond. And so it's kind of cool being here now, my mate Ash, and now he's the Director General of Health. Just the sheer scope of that role is clear just from the questions that have been asked, and it's kind of daunting to even think about taking that on. So I would call on all of us to do whatever we can to support Ashley in his role, and to do whatever we can to be bold and courageous and leaderful. And Ashley, thank you very much for that extraordinary presentation, and thank you for your leadership, and thank you very much for taking time to come and speak to us today.